federal government has sent British Columbia about 1.3 million of these rapid test kits. And I'm just wondering, what are we doing with them?
Yeah, lots of things. I think there was a report that came out from the testing committee, that their task group that they set up nationally, and I know Dr. Mel Krasdem from BC CDC is part of that, and we've been looking at where can we use these. I will also point out that we started to receive them in late October into November. They needed to be validated, but where we have found them to be useful is in some more remote communities where the machines themselves can be used, and if somebody is sick and there's a longer turnaround time to get the gold standard, the nasal pharyngeal swab, to a lab, that we can use those to determine if it is COVID that is causing the illness. And so I've talked about this in a number of times in how do we use it to detect outbreaks, and it is really a single test by itself is not very accurate with these rapid tests. So it is if you have a cluster of people and they have respiratory illness and you test 5 or 6 people and they're all negative, then you can be relatively reassured that it's not COVID. And if any one of them is positive, it tells you that that's likely to be COVID in everybody. So it's an approach that we use with influenza, for example, as well. But what you need to do is have the gold standard as a backup. So we're using it in a number of First Nations communities and more rural, more remote communities where turnaround time is a challenge. We're using some of the rapid tests as well in the downtown east side, where people may not come back to get their result a day or 2 days later, and we need to have the result as best we can then, right then and there. There's been some challenges in using it in those situations, in that they don't perform as well, even in the relative non-cold that we have in British Columbia. We've been using them as a pilot in some places to supplement testing in outbreaks and in long-term care, but they're very resource intensive, and that's what we're learning. The report shows us around the country. We're trying to find where these fit in as a tool, as one of the tools that we can use, and when they best can be used. The other place that we're using them quite successfully is in admissions or remands to our correctional facilities, because then again, it's important to have an understanding rapidly whether that person coming in has this, and we can also back it up with a nasopharyngeal swab. So those are some of the areas that we're using them. It's it's been a challenge.